My, I don't know what part was better, the lecture or the PowerPoint freeness part of it, Richard. Congratulations. So we have a few minutes left to take some questions, and as we have 10 minutes, I'm going to salt some questions here into the panel and see how we can do with them. First of all, I'm going to take what could be one of the big take-home points for the day for most of the audience. Dr. Witterick, you spoke about compliance. Maybe you'd like to expand on that. You think this is affecting what we're seeing in the clinic and how it's getting us results?
Yeah, well, I think that we have very good therapies for many things, but patients will come in and they'll tell you they're doing something, and then the wife will be sitting there and then she's rolling her eyes because you kind of know that he's not doing it. One of the favorite studies that I saw was years ago for an asthma study, and they had a microchip in the inhaler, and they didn't tell patients they had the microchip in the inhaler, and patients came in, they brought their medication in, they were looking at compliance, and the inhaler, when they analyzed it, showed that quite a number of patients discharged their inhaler the morning of to make it look like they'd actually used the medication for that study. So it's just one example of how patients come and tell us that they're doing something, but they don't. And anything that's complicated, I mean, when you do the budesonide rinse and you've got to mix up stuff, you got to boil it, you got to get distilled water, you got to wash the nozzles, and you put it all together, and you know, people go off the wagon on that sort of thing. And so it is a problem. I think our therapies work, but they're involved and they have to have a commitment.
So I think the point is we're not about to be replaced by machines, and that this doctor-patient contact, encouraging patients to take their medication, might actually play the trick. When you think the patient's doing very poorly because their disease is progressing, they may not need a fancier or a more expensive drug. They may simply need to take the one they're taking properly, and that's a terrific point. There was some great talk about an evolution in the endotypes of sinus disease throughout the Pacific Rim, and this evidence is being seen in Thailand and also in Japan and in Korea. There's also some intriguing differences where the level of Staphylococcus is different in Taiwan and in mainland China, simply across the water. And I wonder if you've had any thoughts on this, and has this actually played into how you manage patients?
This question for me, right?
The question would be for you.
Just kidding, yeah. I'm joking. Because I'm spoke about the endotype. So according to your question, so normally we get the polyp tissue for the pathologist, and we communicate with the pathologist that how they should the counting the polyps. Another important issue is before we send the tissue intraoperatively, post-operatively to the pathologist. So we have to be aware that there is no systemic steroid or the topical steroid, but otherwise it will affect the eosinophilic count. But anyway, in my routine practice in Thailand, in Sirat Hospital, normally I did not prescribe the pre-operative steroid because I would like to see the eosinophilic count in my tissue. That will lead me into if I have the eosinophilic polyps, it guides me that this is the steroid responsive, most likely. And for the non-eosinophilic polyps, and if the patient has the negative specific IgE in the serum, so I probably try the long-term low-dose macrolide.
Okay, so we're seeing that there's a surgical histology-based approach to the patient, which is interesting. And speaking of surgery, do you tailor the surgery to the endotype? No, the third speaker.
Tailor the surgery.
No, not specifically. I mean, really, you see what the patient is like clinically in my practice, to be honest. If they come back and there's mucus and pus draining from the sinuses, they're going to need something else done. We don't really have the facility to do anything quite as advanced, I'm afraid, at the moment. Maybe in the future we will. If we're looking at specific monoclonals for things, we're going to have to look at that. But at the present time, no.
And it will all have started in London. There we go. And Richard, I'm going to ask you the question that I know everybody is burning to ask you. Is there a role for 16S in clinic? Just to elaborate on the question, is there a role for culture-independent sequencing of bacteria in clinic? As you know, you can use culture-independent techniques like bacterial sequencing to try and identify the bacterial species that are there, and you get a much wider variety. Now, this is a research technique which is interesting, but we need someone that does both, clinic, research, to tie the two together. Richard, what's the truth?
I can give you the really simple answer, and it's no.
It's a good question.
It's an extremely good question. I can give you the really long answer, but I'll truncate it. I can tell you why it's no. The reason why it's no is because if you do the 16F, if you get the phenotype and you work out all of the phyla, and it's really pretty difficult to get it accurately down to species level without current technology. You can get all the phyla, and there are dozens. It's a zoo in our noses. There are two characteristics which underlie the results to date, because over the last 10 years there have been a lot of studies which have been published. They are, number one, spectacular inter-individual variability. And it would be fantastic if everyone who had CRS had staph or whatever, or something bizarre. And we had a condition like Helicobacter pylori. You know, suddenly we find the bug. But it's not like that. Everyone's got their own fingerprint in their nose. So that makes it really hard then to recommend rational antibiotic treatment. The second thing which characterises the microbiome between the groups of patients with CRS, and I exclude, and I've just seen that Christian's just walked in, and he knows more about CF than just about anybody, and so CF's excluded from this, because the CF guys are weird, and that's mostly because what the respiratory physicians have done to them, which is, since they were very young, soak them in antibiotics.
Richard, with that, we're going to have to turn the rune over to the next group, so remember that.
I was just warming to my theme.
With antibiotics. So that's what Richard does, soak them with antibiotics.
No, I don't, no.
It's hard to catch it. So I would like to thank the panel for participating. I'd really like the audience to thank you for turning out in such great numbers. I think this is a great area of CRS, and enjoy the rest of your meeting. Thank you.